a big introduction for me. No, it is not me which is important. It is you which is important for whole society and extents of India.
Yeah.
Due to you people, we are doing this program, and program is very successful. I will thank my master teachers for helping me a lot in this endeavor. Thank you very much, Dr. Ajay. Thank you.
Thank you, sir. Thank you, everybody, all the stalwarts of API who have driven us to do this program. And this time, I requested Debika, who was there in Patna, for a meeting. And she is a very kind lady, I must tell you. Always, whenever I request her for any program, anything, she always says yes. And before I tell you something about her, she is a phenomenal human being, a phenomenal lady, a God-gifted talent, and echocardiography, she has mastered every bit of it. And when she will teach you, then you realize how beautiful her teaching methodology is. She is a faculty HOD of echocardiography and non-invasive cardiology at Rabindranath Tagore Institute of Medical Sciences. And she has had many accolades in her life. I am personally very greatly inspired by this teacher and young lady. Over to you, ma'am.
Thank you, Dr. Sinha, for that kind introduction. Though I don't deserve everything, yeah, it is, you have said so many things. Anyway, so without wasting time, let me start the basics of echocardiography for the physician of India. And I will start sharing my screen. Can you see my screen?
Yes.
Yes.
Yes. Yes.
And
Yes,
I'm audible also. So,
yes. Very audible.
Okay. So, echocardiography has become a very integral part of the clinical practice. Every day, in each and every step, we need this mode of investigation. So to start with, let me show you a case. A 20 years old young boy almost, he was in a gym, he was exercising, had sudden cardiac arrest, somehow resuscitated, and he was sent to our hospital. Now see, with the help of 2-3 images, we could come to a diagnosis. So here, the parasternal long axis is showing the asymmetrical septal hypertrophy, which is also seen in the apical 4-chamber view. And then as we do the 5-chamber view and put the color flow, we see that there is severe LV outflow tract obstruction, and with continuous wave Doppler, we get a gradient of 63 millimeter of mercury, so which is quite high. So with the help of 2-3 views, we could come to a diagnosis in the emergency. So he was suffering from hypertrophic cardiomyopathy with severe LVOT obstruction, which is the cause of his sudden cardiac arrest while doing the exercise in the gym. So that is the magic of echocardiography. Very comprehensively, it says the cardiac structure and function. It can be done at bedside whenever you want, wherever you want, because it's bedside. A very safe, very non-invasive, no radiation, no iodinated contrast, and it can be repeated at your will. And what are its role? Just now you have seen is if there is any hemodynamic compromise, patient presenting with respiratory distress, a patient with fever, chest pain, arrhythmia, thromboembolic complications, and thus it also helps us in therapeutic guidance after coming to the diagnosis. So this is echocardiography, which has evolved tremendously over last 60 years from a simple A mode, M mode, B mode to color Doppler, tissue Doppler, three-dimensional echo, transesophageal echo, strain imaging. So what it is basically the ultrasonography of the heart. What produces the ultrasound? It is the piezoelectric crystal inside the transducer or the probe, we say, which emits the ultrasound wave and which also can receive the reflected ultrasound wave from the heart. And then the machine amplifies the sound wave, filters, does a lot of processing to create an image, which we see. It is a virtual image, but you have a feeling as though, just like cardiothoracic surgeon, you are having a look at the heart. But it is a really virtual image processed by the machine. And you must have seen there are lots of probes hanging from the echo machine. Now, how do you select the probe? Which probe to select? This one, that one? So here also we use principles of ultrasound wave while selecting the probe. The physics says that frequency is inversely related to wavelength and tissue penetration is directly related to wavelength. So obviously for an adult, we'll need a longer wavelength, and that is why we use the lowest possible frequency probe for an adult and the highest possible frequency probe for a pediatric patient. Of course, with the low frequency probe, we compromise with the resolution. Never mind, we have to get the image. We have to have a longer wavelength to get an image in the adult patient. So we trade off between the resolution and the penetration. Now, there are three modes of, basically three different modes in the echocardiography. Other than the color Doppler, it's the M mode, B mode, and three-dimensional. For the basics, I haven't kept the three-dimensional echo, so I will go with the M mode, B mode, along with the color Doppler. Now, what is M mode echocardiography? Well, it is the one-dimensional view of all the structures along one line. So it will vary according to the placement of the line. So if it is a parasternal long axis and your line passes to the aortic valve, which is closing with a single line of closure and opening. So if it passes like this, you will see the structures along this line of cursor. So here, see the line of closure of the aortic valve. And so end up diastole, the systole begins, aorta opens with a rectangular box, and then again closes. Along with that, aortic root dances. So in systole, it goes up, and then again diastole, it goes down. So these aortic root dancing, along with opening and closure of the aortic valve, can be appreciated in M mode echocardiography. If you take your line of the cursor over the mitral valve, you will see the mitral valve inside the left ventricle. Here's the right ventricle, interventricular septum, and the mitral valve. So if you look here, AML moves towards the septum and PML moves towards the posterior valve. So also in the M mode, the AML moves forward towards the septum and PML moves backward towards the posterior valve with a mirror image pattern. So this is the AML and PML during diastole, and during systole, you see they walk hand in hand in the M mode. So this is picked up by M mode echocardiography when there is systolic anterior motion. You see, during diastole, they open up. The AML goes forward, PML goes backward. But in systole, they are supposed to be hand in hand. But here it is again moving and it's touching, AML is touching the septum. So this is called systolic anterior motion. It is a sign, it is a specific sign, around 98% specificity for hypertrophic cardiomyopathy. As you can see, this case was the first case which I have demonstrated. Now, if you move your cursor towards the left ventricle, you get to see the LV in its diastole, systole, along with the septum and the posterior wall. And from the M mode, let us move to the
मम्मी को बोल दिए
B mode or two-dimensional echocardiography. So
बैठिए
what is that? See,
हाँ.
there are multiple scan lines, around 160 scan lines of ultrasound beam, which are swept over this sector of 90 degree to get an image, two-dimensional image. So it's basically a sagittal section of the heart from the base to the apex. Though in parasternal long axis, we are not supposed to see the apex. So basically, we see a part of the heart from base towards the apex. Now, what are the movements of the probe or the transducer we make while doing the echocardiography? So one, you know, this is the precordium. So as you can slide the probe anywhere over the precordium, that is called sliding movement. And if you look here, there is a marker here in the probe, which we call orientation marker. So in reference to this, we rotate the probe either clockwise or counterclockwise. Or we tilt the probe, maybe cranially or caudally or side to side. So these are the movements which we make with the probe to get standard images. Now, so to start, we expose the chest, we turn the patient to the left lateral so that the heart comes closer to the chest wall and you get a better quality image. And then you apply a gel on the transducer and place the transducer on the patient's chest in the echo window. Now, why do we apply jelly or gel? It is because the gel promotes the acoustic coupling. It minimizes the attenuation due to mismatch at the air tissue border. So if you do echo without jelly, it looks like this, which is not acceptable. You have to apply some jelly to get an optimized proper image. Now, and then how much should be the depth? See, in this particular adult patient, heart is only here, whereas here it's very big and here it is optimum. So with which reference I'm telling that this image of parasternal long axis is optimized? I look at the descending thoracic aorta. See, you can see the descending thoracic aorta. It should be at the lowest, the posterior aspect of this sector, that imaging scanning sector. You should be able to see it at the lowermost part, not very high, not very low. If you make it too low, then it gets cut. A part of the left atrium also gets cut. So the optimum is to keep it at the most posterior aspect. So also in the apical four-chamber view, it should not be very big, I mean very small, so that the RA and LA got cut. It should be fully seen inside the scanning sector. So your overall gain should be such that it is optimum, neither too bright nor too dark, and there is and this overall gain is controlled by a single knob, and another gain setting is there, which is called the TGC or time gain compensation. So it is a depth-dependent gain control. Now in the imaging sector, here is the probe. This is the most anterior part of the imaging scanning sector, and this is the most posterior. So anteriorly, the ultrasound is very strong. So we need the minimum gain. So the knob is on the extreme left, whereas in the posterior aspect, as the ultrasound passes, it gets scattered, it becomes less powerful. So you need a higher gain there. So that way we adjust the TGC gain. And the color and this width of the image should not be very big. It should be small as possible, yet to cover the region of interest. Because wider skin reduces the frame rate. Your image quality will be compromised. Look at these two images. You can really appreciate the clarity of this image where the width is optimum. Now let us see what we mean by echo window. So the echo window means the places over the chest where the ultrasound reaches the heart without being obscured by the ribs or the lung tissue. So what are those places? It's like window of the room or the house where air can pass. So here we are utilizing those spaces to send the ultrasound wave. So obviously that will be in between the ribs. The ribs are not good conductor of sound wave, ultrasound wave. So we select the intercostal space, the subcostal space, and the suprasternal. So these are the windows for doing the echocardiography. So using such window, you maintaining those optimization of the image. Let us start the views. The first view which we get is the parasternal long axis view, where we place the transducer in the left parasternal third or fourth space, intercostal space, and the marker pointing towards the patient's right shoulder. And you get a view like this, where you see the part of RV outflow tract. It's a sagittal section. Then you get the left ventricle with part of its anteroseptum, basal and mid, and part of the posterior wall, basal and mid. The mitral valve with AML and the PML, the left atrium and the aortic valve, the RCC at the top, and either NCC or LCC at the bottom, which we will confirm in the parasternal short axis, and a part of the aorta. So we look at the size of the chambers, especially the LV and the LA aorta. Also, we look at the systolic function of the LV. See, this ventricle is normal in size with good systolic function. But if you look here, this ventricle is dilated, definitely dilated, left atrium is dilated, and look at the systolic function, the systolic thickening of the myocardium. It is definitely less. On the contrary, these particular image, we see that LV is dilated, LA also is dilated, but LV is showing good contraction. So this is the way we assess the size of the ventricle, left atrium, and also the systolic function. And then also there are other ways to confirm those. We also look at the LV for its hypertrophy of the walls. Now here, if you look, there is a concentric hypertrophy. This particular patient is a known case of hypertension for last 5 years. So what we find that there is a hypertrophy of the septum as well as the posterior wall, almost similar hypertrophy. So it's called concentric LVH. On the contrary, if you look here, look, the septum is much more thickened than the posterior wall. So we will tell this asymmetrical septal hypertrophy. So these are the applications of parasternal long axis. And Not only that, we also look at the mitral valve. Look here, this particular mitral valve, it's showing the changes of rheumatic mitral stenosis. So how do you know that? Look at the AML, there is a diastolic doming. The PML is fixed, chordae are thickened, left atrium is enlarged. So it is, and look at the opening. Its opening is much less. So it's a case of mitral stenosis. Now, on the contrary, if you look here, see, these valve also showing the rheumatic changes, thickened, restricted motion, fixed PML. But during systole, they are not coapting. This valve is coapting, so it's a pure case of mitral stenosis. But here, if you see, there is a non-coaptation of the leaflets. And as you put the color flow, you see a lot of mitral regurgitation. So this particular valve is mitral regurgitating valve of rheumatic origin. So looking at the valve, we can come to a diagnosis, and which we confirm by looking at the other views and using the other modalities of echocardiography. We start looking at each and every structure from the very first view, so that we keep the image in the back of my mind, and to come to a diagnosis. If you look here, look at the aortic valve, how calcified it is. There is hardly any opening. So this patient will definitely have a significant aortic valve stenosis. Maybe it is severe. So now here is another boy, 15 years old boy, came with history of fever and repeated TIA, the transient ischemic attack. So the neurologist sent the case to us, and we found this patient had a bicuspid aortic valve. And look here, there is a large mass, and from their tentacles, like the structures are projecting. These are the vegetations. Patient had a very high leukocyte count, and CRP also was high. So basically, we are dealing with a case of infective endocarditis. And look at the movement of the vegetation. They are moving independently, out of phase, not following the cardiac cycle. So these are the various uses of parasternal long axis. Another very important use of parasternal long axis view is the identification and diagnosis of pericardial effusion. And also, often we come across with patients who are in failure, having pericardial effusion and pleural effusion together. So this is the descending thoracic aorta. I have already told you in the beginning. And in this image, it is the descending thoracic aorta, and here it is the descending thoracic aorta. This particular effusion is only anterior to the aorta, whereas if you look here, there is a effusion here, and with the boundary wall posterior to the aorta, there is some other effusion. So the anterior to the aorta is the pericardial effusion, and the one which is posterior to the aorta is the pleural effusion. So this is the way we differentiate between pericardial effusion and pleural effusion. Now, moving to the parasternal short axis from the parasternal long axis. So this is basically transection of the heart at different levels. So what we do, from that parasternal long axis, we rotate the probe clockwise by around 90 degrees, and then we have to tilt the probe anteriorly, so that we reach the ultrasound reaches the basal level where there are great arteries. So the view which we get, you see, this is the aorta in the middle, and it is wrapped around by the RVOT and pulmonary artery. This is the pulmonary valve, and a pulmonary artery is bifurcating into RP and LP. So now what is the use of this view? See, we look at the number of cusps of the aortic valve. here. As I said, the three cusps, see, this is the left atrium, pulmonary artery, and right atrium. So the one along with the interatrial septum is the non-coronary cusp. The one with along the alveoli is the right coronary cusp, and this is along the left atrium. So this is left coronary cusp. Now look at this patient. It's very clear that this patient is having two cusps. So it's a bicuspid aortic valve. It is the commonest asymptomatic congenital heart disease, and especially we get in adult. They often come with the fever, or the vegetation, endocarditis, aortic stenosis, aortic regurgitation, etc. And once in a while, very, very uncommonly, we get quadricuspid aortic valve. Have a look at this patient. There are four cusps, 1, 2, 3, 4. The quadricuspid aortic valve is very, very rare, which we get with an incidence of 0.01 to 0.04% population. So quadricuspid aortic valve. Then we also looking at the parasternal short axis view at the level of great vessels, you can see the infundibular and valvar stenosis in a case of tetralogy of Fallot, who presented at around 24 years, a pink Fallot, but if you look at the turbulence and the RVOT, it's starting from much above the valvar level. So you confirm it with CW Doppler. So we use this parasternal short axis view at the level of the great vessels and the various disease condition. Now moving towards the mitral valve, you have to tilt the probe posteriorly from that position to reach at the level of the mitral valve. This is the left ventricle in the short axis, and you see all the 6 segments of the left ventricle. This area is the LAD area, then is the LCX, then is the RC area. You can see a part of the right ventricle also, and this particular structure in the middle of the left ventricle is the mitral valve with its anterior leaflet and the posterior leaflet. Now, these are the commissures, anterolateral and the posterior medial commissure. Now, we use this view for diagnosing the mitral stenosis. Look here, how small is the mitral valve opening. Here it is so big, a normal valve. In comparison, this is only this much. And moreover, there is a lot of calcium at the anterolateral commissure. So this valve is contraindicated for balloon mitral valvotomy. We also use this view to measure the mitral valve area. We call it planimetry of the mitral valve from this particular view to assess the severity of the mitral stenosis in this particular patient. The mitral valve area is only 0.44 square centimeters. So very small mitral valve case of critical mitral stenosis. Now, we also look at the regional wall motion abnormality, and you can see these area, the LAD territory is scarred, whitish, and not moving like other areas. And let us move further towards the papillary muscle from the mitral valve with the posterior tilting. As you can see, this is the LV, RV, and look at the 2 papillary muscles. So this one is the anterolateral papillary muscle, and this particular muscle is the posteromedial papillary muscle. So this ventricle is contracting very nicely, normally, with all the segments showing systolic thickening during the systole, which is a very, very good sign for good systolic function. Now, as you have seen, there are 2 papillary muscles, but in this particular patient, a 14-year-old boy, no history of rheumatic, history suggestive of rheumatic fever, presented with SOB. Now, in the parasternal long axis, it looks like it is a case of mitral stenosis. But look at the short axis of the left ventricle at the papillary muscle level. I can see only one papillary muscle. There is no trace of the second papillary muscle, posteromedial papillary muscle. So what we are dealing with? Look at the mitral valve. It's exactly looking like a parachute. See, it's a parachute. So all the cordae are getting attached to the anterolateral papillary muscle, and as a result of which the mitral valve looks like a parachute, and giving rise to the to the mitral stenosis. As you can see, the four-chamber view is showing turbulence across the mitral valve with a mean gradient of around 7 millimeter of mercury. So we are dealing with the case of parachute mitral valve, which we could diagnose by the finding of single papillary muscle. Now, we also look at the regional wall motion abnormality at the papillary muscle level. As you can see here, the LAD territory is scarred and akinetic, but RCA and LCX territory are contracting very nicely. On the contrary, if you look at this patient, it is the RCA territory which is moving less. Look here, the LAD territory, LCX are contracting well, but the RCA territory is muscle mass is lost along with the akinesia, no movement at all. So that way we come to the diagnosis, we utilize the views. And then this view is called the parasternal short axis view at the level of the apex. We look at the regional wall motion abnormality. This particular apex is contracting very well. Now moving to the apical views, basically, from the parasternal long axis and short axis view. Now we have moved the probe to the apex over the apical impulse, maybe in the anterior clavicular anterior axillary line or mid-clavicular line, or it varies depending on the size and the shape of the heart. So you keep the orientation marker at around 3 o'clock or roughly towards the patient's left shoulder. And the first view you get, and you have to look up, you have to scan the heart from the apex to the base. So you get a picture like this, where you see all 4 chambers of the heart with 2 AV valves and 2 ventricles, 2 atria, and IVS and IAS in the single line. So these makes a proper apical 4-chamber view. Look at the LV. LV should be bullet shaped. It should not be roundish. If the LV apex becomes roundish, we call it foreshortened LV. So you shouldn't get that type of view. You should, if you get a roundish apex, you should move your probe down and out further to get a view like this. Now, from the apical 4-chamber view, if you tilt the probe anteriorly, keeping it in the same place, then you get a view called apical 5-chamber view. Why it is called 5-chamber? Because the aorta opens. If you see, the aorta opens from the ventricle. Now, in the apical region, we get another 3 views. One such is called the RV focused view. This particular view is used for assessing the RV size, RV systolic function. We can see the entire RV free wall. This view is little different from the apical 4-chamber view. If you look here, the apex, LV apex is at the center, and it is sitting over the RV, so that you maintain this particular view for measurement, because RV looks very different if you move the probe little to the parasternal area or little outside. So this particular view is used for assessment of the RV. We also get the apical 2-chamber view by rotating the probe counterclockwise by around 60 degrees from apical 4-chamber view. where you see the anterior wall and the inferior wall, this side, and further counterclockwise rotation by around 20 degree, we'll open up the aorta from the left ventricle, and we call it apical three-chamber view, LV, LA, aorta with the aortic valve and the mitral valve. We use the apical four-chamber and two-chamber to measure the LV ejection fraction. It is the current recommendation by American Society of Echocardiography for measuring LV ejection fraction. It is called biplane disc summation method. So once in end diastole, we freeze and measure the volume in the apical fourth chamber, repeat it in the end diastole, and repeat the same process in two-chamber view to get an ejection fraction by biplane method. So this is the standard method for measuring the LV ejection fraction. We also use the apical four-chamber view to look at the regional wall motion abnormality, which is the hallmark of ischemia, as I said, and it corresponds closely with the coronary artery blood supply. If you look, the LAD is obstructed, and it is the LV apex which has become akinetic and scarred. If we look at this case, you will understand the utility of this apical views and echo views to come to a diagnosis in a very, very critical patient. Here is a 76 years old female, hypertensive for 10 years, presented at the emergency room with ongoing intermittent chest pain, central chest pain, typical anginal pain for 3 days. Now we do the ECG, and we don't know whether it is this deep T wave inversion, starting from almost V3, V4, V5, V6. And so patient is hypertensive. Is it due to LVH with strain pattern, or is it due to so much of deep inversion of T wave? Is it due to hypertrophic cardiomyopathy? Or since the patient is having chest pain, is it due to Wellens syndrome? So we do the echocardiography. In long axis, we see mild concentric hypertrophy. So the hypertrophic cardiomyopathy is ruled out. Then we go to the four-chamber view. Go to the fourth chamber. Yeah, we get the diagnosis. Look at the apex. Hardly there is any thickening of the myocardium. And look at the two-chamber view, apical to the entire anterior wall is standstill. There is no thickening. Only in the inferior wall there is thickening. It is the lateral wall which is getting thickened, but this part is not getting thickened. So our diagnosis is Wellens syndrome. So the patient has undergone a quick angiography, which showed a very, very critical stenosis of the LAD, and it was opened.
और वापस आएगी
ये वाला गेट खोल दिया है
डॉक्टर की बेचारे को भी अपग्रेड होने का
इसमें है तो जुनैद को 3 बार
5 शानदार benefits, आसान फाइनेंस
एलिवेशन वाला आज बन वाला
जी अपने नजदीकी नेक्सा शोरूम में जाएं और पाएं 1 लाख
वो
की
चल रहा है ना,
3 साल की वारंटी
क्या?
अभी तो वो चल रही है ना।
केवल एक सरगम वॉशिंग पाउडर में नया क्या है?
नई बात ये है कि सरगम सिर्फ पाउडर नहीं, वॉशिंग पाउडर है।
मतलब
पाउडर तो पानी में घोलता कौन है? मैं।
Hello, Anand.
इतनी मेहनत करता कौन है? मैं। मतलब वाटर।
कहाँ चले छुप गया रोज।
Anand, there is a lot of disturbance. Please.
आंसर बेटा पेटेंट देगा तो
ये मास्टर साहब, नए सरगम।
साढ़े
मैं
3 बजे शाम
सुबह के से बोलता हूं हमें बोलना मैं
ये सुबह तक फोटो लेने पड़ेगा
और मैं
कंटिन्यू तो
एडमिट वाला ही होगा
कर लेंगे तो कोई दिक्कत नहीं करने की वजह
जबरदस्ती नहीं करते
कभी नहीं केवल 4:30
बाकी गर्मियों में एक ग्लास रोडोसा वाली से ले तो मैं फिर अब
ठीक बना है आज तो फाइनल है अच्छा भी बना है तो वो कुछ आगे पीछे बात हम कर
अच्छा ये बिल्कुल प्रीति की मम्मी जैसे देखो है।
Hello.
आ रही है ट्रेन से रूम में
Hello.
Hello, Anand. Hello, Anand.
Hello. Can I start again?
Yeah, please go ahead.
Because there was some disturbance.
No problems. No problem.
Okay. So it is a critical LED stenosis, and our diagnosis was correct from the wall motion abnormality in the echocardiographic views. Such important is the four-chamber view, which gave us the proper diagnosis. And look here, looking at the apex, you find a thrombus following the myocardial infarction, a discrete echo-dense mass, and with well-defined margin. And you can see throughout the systole and diastole, and also in two views. So post-MI thrombus, you can diagnose mitral stenosis, looking at the valve, look at the flow, a turbulent flow. And then also this lady, 40 years female, went to the neurologist with acute severe headache and hemiparesis. MRI showed an ischemic lesion, so young ischemic lesion in the brain. So young ischemic stroke is the cause, and we have to find out the the cardiac embolism, source of cardiac embolism. So as we did the echo in the four-chamber view, we could see a large mass, and it is the myxoma. It is attached to the eyes in the region of the fossa ovalis, and look at the surface. It is a villiform. So a part of it must have must have been torn, and it has dislodged, and it was embolized, leading to the stroke in this particular case, or a thrombus may be formed. So our diagnosis is made only by looking at the apical four-chamber view, and so each and every view is very, very important. And the importance of apical five-chamber view. Look, the aortic valve. Look at the aortic valve, densely calcified. We put the color flow. Only a tiny flow goes forward to the through the aortic valve in this particular aged male who presented with chest pain, SOB, repeated syncope. You get a systolic murmur on auscultation, and ECG shows LVH. And so you immediately come to a diagnosis that you are dealing with a case of severe aortic stenosis. So moving to the subcostal view from the four-chamber view, which is a very, very important view for all of us, this subcostal view. Patient lies supine, probe in the subxiphoid area, and orientation marker at 3 o'clock position, and we direct the probe towards the heart. You get a view like this. This is liver, left atrium, left ventricle with mitral valve, and this is the RA, IA is in between, tricuspid valve, and the RV. Now, this is the view where you can see the interatrial septal defect very nicely, and if you put the color flow, you will see a very, very, you will appreciate the flow across the ASD. And further important view from the subcostal window is the view of inferior vena cava. So how do we get it from the subcostal four-chamber view? We rotate the probe by 90 degrees and anti-clockwise, and so our orientation marker is now at 12 o'clock, and IVC is seen draining into the RA. And this is the liver. It is joined by the hepatic vein, and it drains into the IVC, into the RA. It is very, very important to demonstrate that IVC is draining into the RA, because aorta is very nearby, and if you mistake the aorta as the IVC, you may give the wrong information and your fluid therapy may change. So please keep it in mind that you should demonstrate the IVC draining into the RA. So it is these IVCs are normal in size. It is very important in a patient with hypertension to demonstrate. You see these particular IVCs very smallish. So there is hypovolemia. You'll have to give fluid in this patient, in this type of patient. Whereas in this particular patient, the IVC is dilated and it's showing no respiratory variation. Normally, the IVC collapses more than 50% during inspiration, as in this case, but here it is not moving. And we always ask the patient to sleeping, collapse, dilated and IVC. And this we are dealing in this particular patient, either with constriction or restrictive cardiomyopathy or tamponade. So utilization of this subcostal view, look at this patient, 40 years old man, severe SOB, we get a dilated fixed IVC. And in the fourth chamber, you see there is a huge pericardial effusion along with the collapse of the RA and RV. So what is the line of management in this particular patient? There is no time. There is hypotension. Patient is tachycardic with 135 rate. So you have to immediately do the pericardiocentesis to save this particular patient. You are dealing with cardiac tamponade. No time, immediate therapeutic intervention with pericardiocentesis. So coming to the suprasternal view, you get in the suprasternal notch, patient supine, neck extended, transducer in the notch, and your orientation marker is towards the patient head. If you put the color flow, the flow in the ascending aorta, this is the arch, descending thoracic aorta. You can see the two branches, second branch and third branch. So ascending aorta flow is red and descending aorta flow is blue. So we utilize this view to diagnose and see the dissection flap can be seen. The extension of the dissection flap, here it is up to the arch of the aorta, and in this particular patient, the dissection flap, the intimal flap in the aorta is seen in the descending thoracic aorta. So with further examination, you confirm the diagnosis and also you comment on the extension of the dissection. We also can identify coarctation of aorta. Now look here, the descending thoracic aorta after the subclavian has become very narrow with a turbulent flow and this type of flow pattern. So it confirms the diagnosis of coarctation of aorta. Moving to the Doppler echo from the two-dimensional echo now. So our M mode and two-dimensional echo are over. Now we are moving in a different area, which is called Doppler echocardiography. To understand how, when, and which to use, and also to understand the importance of Doppler echo, let us see a case. A 15-year-old male coming to you with history of repeated lower respiratory tract infection. You do the two-dimensional echo. What you find? Dilated LV, dilated enlarged left atrium, good contraction, valves normal. The apical fourth chamber also shows good biventricular systolic function with dilated LA and LV, and parasternal short axis also looks quite normal. No thrombus, nothing is there, no abnormality, no stenosis. So what it is, we put the color flow in the parasternal long axis view. What we find? There is a small perimembranous PSD with left to right flow You see, and the flow is going from the left to the right towards the probe with a very high gradient of around 110 millimeter of mercury. So that confirms the diagnosis of a small perimembranous VSD. Now, and the thing is that with that small perimembranous VSD, can you explain so much of dilatation of the LV and the LA? Well, obviously it is not. The smaller the VSD, less will be the dilatation of the LV and the LA. So what it is, now we put the color flow in the parasternal short axis view at the level of the great vessels. You see, this is the pulmonary artery, this is the descending thoracic aorta. Look at the flow. Here there is a continuous systolo-diastolic flow. So it is a case of, in addition to the perimembranous VSD, this patient is also having a patent ductus arteriosus with continuous left to right flow, which explains the so much of dilatation of LV and LA. So in two-dimensional echo, we have this limitation. We are unable to visualize the blood flow. Blood is there, which is seen as the black color, but we cannot visualize the blood flow. A limitation of two-dimensional echocardiography, which we overcome with the Doppler echocardiography, because Doppler echocardiography not only identifies the direction of the blood flow in the heart and the great vessels, it also calculates the velocity of the blood with which it is flowing across the valve or across the some defects like VSD, and it provides the hemodynamic information. So you are utilizing the same instrument, same principle of the ultrasound wave, but you are asking a different question. That is the Doppler echocardiography. And that Doppler echocardiography was originally, that Doppler principle rather was discovered by a scientist. His name is Christian Doppler. He came with this frequency shift formula around 250 years back in Austria, where we can, utilizing that principle, we can calculate the velocity of the blood now, and as we can, you can assess the velocity of the blood, and with the help of modified Bernoulli equation, we can also estimate the pressure gradient across a valve or across a VSD, across a PDA. So in this particular case, that severe aortic stenosis, the very small flow, forward flow. So we do a continuous wave Doppler, and we get a velocity of 5 meters per second. So if you multiply it 4 into 5 square, it becomes 100. And look at the big gradient, it's 100 millimeter of mercury. So this is the, this is the way we overcome the limitation of two-dimensional echocardiography. We assess the flow, we assess the gradient, and come to the severity of the aortic stenosis. In this particular case, the mean gradient is 58 millimeter of mercury, which indicates it's very, very severe form of aortic stenosis. So if you look at the display format of Doppler echo, basically we have two types of display formats. One is the spectral Doppler, which is represented in the graphic form to get the velocity, and another is the color flow mapping. Okay, so in both you get the information about the blood flow velocity and its direction. Here we know that it's going from the left ventricle to the right ventricle, so left to right flow. And here you know that it is above the baseline, so the flow is going from
Everything in the control.
towards the probe. And in the spectral Doppler modalities, there are the two forms. One is the pulse wave Doppler, another is continuous wave Doppler. And in the pulse wave Doppler, you determine the blood flow velocity by sending the pulses of ultrasound wave at a specific site of interest. What is that specific site of interest? It is the sample volume. So what it is actually, it is like a gate. You are getting the blood flow velocities which are moving of the blood cells which are moving within this gate. So basically, a single crystal, piezoelectric crystal, transmits the pulses of ultrasound wave to reach the site of sample volume, and then the same transducer waits and receives the reflected signal. So transmit, wait, receive form is repeated to get the velocity of the blood cells within the sample volume. So how do we do that? Again, the 4-chamber view. Say suppose you get the cursor, this is the sample volume, you place it at, if you want to get the velocity across the mitral valve for assessment of diastolic dysfunction, you keep the sample volume at the level of the tip of the mitral valve and switch on the pulse wave Doppler, and you get a velocity curve like this, E and A. It is the E represents the early rapid filling phase and A represents the late rapid filling phase. So it's site-specific information. We utilize it for assessing the diastolic function. We utilize it for seeing the flow pattern in the pulmonary vein. It is the pulmonary vein here. Below the, it is at the roof of the left atrium. So we place the sample volume here and do the pulse wave Doppler. We see a systolic wave, diastolic wave, and a flow reversal in the pulmonary vein. So it's very, very site specific. It will pick up only the structure where you are placing the sample volume. Now, also we utilize it in determining the situs from the subcostal view. This is the spine of the vertebra. Aorta is on one side and IVC on the one side. So we confirm that this is aorta by looking at the pulsatile flow, and in the IVC it's a continuous flow. So we confirm that IVC on the right of the spine and aorta is on the left of the spine, and that confirms that it is situs solitus. But pulse wave Doppler has got a disadvantage. It is unable to record the blood flow velocity more than 1.5 or say 1.7 meter per second. And this is the limit of the pulse wave Doppler. It is called the Nyquist limit. If a particular patient is having a velocity is more than this, you will get aliasing. So how does it look like if you are dealing with a patient of mitral regurgitation? Say suppose and you are doing the pulse wave Doppler, the forward flow is okay because forward flow, there is no obstruction. And in my MR, the part of it is cut and truncated, and the truncated portion has gone up. Because with CW Doppler, you see the velocity is 4.8 meter per second, which is pretty high. It has crossed the limit of pulse wave Doppler. So that is why there is aliasing. So what is the solution? Either you shift the baseline up, increase the pulse repetition frequency, or the best is to shift to the continuous wave Doppler. Well, what it is, so what is the difference? See, here the sampling is continuous. There are two crystals. One is sending the signal and another is receiving the signal. So continuous sampling is the one which is used in continuous wave Doppler, as a result of which there is no aliasing, no Nyquist limit. So you can record a very, very high velocity flow, as in this case of mitral regurgitation, a velocity, very high velocity also is picked up fully by the continuous wave Doppler. Now, what are the uses of continuous wave Doppler? As I said, a case of aortic stenosis, I have already shown you. A gradient we can identify and we can assess the severity. In this particular case, it is 58 millimeter of mercury, which is the mean gradient. So that indicates we are dealing with severe aortic stenosis. So also this TRZ gradient, you place a cursor to get the TRZ gradient, and you see that it is 68 millimeter of mercury. Now looking at the IVC, we can, which I have shown you in the subcostal view, looking at the size and collapsibility of the IVC, we can assess the RA pressure, which is normally 3 to 5 millimeter of mercury. So we add that with this 68 millimeter of mercury to get the RV pressure. And in absence of pulmonary valve stenosis, this reflects the pulmonary arterial systolic pressure. So this is the use of continuous wave Doppler. We also use it to look at the mitral valve stenosis and looking at the mean gradient across the mitral valve to know the severity and of the disease. But we must remember that that our cursor should be absolutely parallel or near parallel to the flow, because there is a chance of underestimation of the velocity if there is an angle error. If there is 20 degree angle, then there will be 6% error, but it increases to almost 0 in 90 degree, because if you look at the formula of the velocity of the blood, there is a factor of cosine value. You know that cosine 0 is 1, but cosine 90 degree is 0. So everything will be multiplied with 0, giving you an error in the calculation. So you have to be parallel. So to show you that you have to be parallel, look here, the TRZ gradient, and I'm placing the cursor. Look, there is an angle, and I am trying to get the continuous wave Doppler of the TRZ. How much is the gradient? It's 48 millimeter of mercury. But the next, I make it parallel to the cursor. The TRZ is now absolutely parallel. And how much is the gradient? It's around 60 millimeter of mercury. So there is an error if your cursor is not parallel to the flow which you are going to assess with the continuous wave Doppler. And also this problem, the problem that it is not site specific, that is a disadvantage of continuous wave Doppler. So it is an example where you may face the disadvantage of not site specific quality of a CW Doppler, unlike pulse wave Doppler. You are trying to assess the maximum gradient, but at the same time, you have to be very, very careful because it is not site specific. So it will pick up the gradient on its way along the cursor. So this is a case of hypertrophic cardiomyopathy. If you see, there is some amount of mitral regurgitation here. So as I go to assess the pressure gradient across the LV outflow tract, I open up the LV outflow tract a bit and to get the LVOT flow. And also remember that there is some regurgitation, which I have shown you. Yes, I can see here. Now, as I get the CW Doppler, I can see two signals. Now, by mistake, if you pick up the MRZ gradient and tell that this is the LVOT gradient, it will be a mistake, it will be an error, because LVOT gradient is actually this one, this dagger shaped, and the bigger one is the MR. It's crossing the 6 meter per second, which is absurd. So LVOT gradient is 55 millimeter of mercury in this particular patient. So be careful about the CW Doppler when you are dealing with a case of hypertrophic obstructive cardiomyopathy because these patients have the MR. So CW Doppler signal will pick up not only the LVOT turbulence gradient, as also because the cursor is so parallel to the mitral valve regurgitation that it will pick up the MR also along with it. So never measure the MR jet gradient and comment it as LVOT gradient. Look at the dagger-shaped spectrum which comes from the LV outflow tract. CW Doppler spectral display at any given moment of time, it shows two things. One is the blood flow direction, another is the velocity. Now look, this is the apical 5-chamber view. There is a disease in the aortic valve. The forward flow is turbulent. There is an AR jet also. So AR jet is leaking, the valve is leaking, the flow is going towards the probe, and forward flow is away from the probe. So as you get the spectral form of the Doppler, you see above the baseline is the regurgitation, and below the baseline is the aortic stenosis spectrum. So also in the color, the color flow mapping. So there comes the color flow mapping, which I have just now explained you. If this is the probe, here it is probe. So the flow which goes towards the probe is the red color, and which goes away from the probe is the blue color. So the red flow is going from the LA to the LV, and that blue flow is going actually towards the aorta, which is not yet open. Now, on this particular patient, doesn't have any mitral regurgitation. You see, there is no blue color in the left atrium. On the other hand, if you look at this patient, there is an MR. So that is the way we diagnose the presence of mitral regurgitation. The red flow is the forward flow, and this particular blue flow, which is coming in the systole, is the mitral regurgitation jet. And also you can see there is an ostium secundum ASD, and the flow is going towards the probe from the left atrium to the right atrium. So there is a left-right flow, and here is a VSD, the one which I have shown you with the left-right flow. But look at these VSD. It's a case of tetralogy of Fallot, a large VSD, and there is a bidirectional flow. Can you appreciate the blue and the red flow? So there is a bidirectional flow across these VSD. On the contrary, in this particular patient, the VSD flow is only left to right, going towards the probe. So this way we differentiate between the direction of the flow. And when we put the color flow, we say this type of flow when there is no obstruction, we say laminar flow, where all the blood cells are moving in the same direction with same velocity. But we say turbulent flow when the blood flow comes across an obstruction. You see there is mitral stenosis, and so the forward flow is turbulent, and it has developed a mosaic pattern. So it's a turbulent flow because the blood cells are moving in different directions with different velocities. And a little bit about the optimization in color Doppler. You need to keep the color scale at around 50 to 60, never at the scale of 30. You will get a smudging of the color pattern, and the color gain should be optimal, not very not too low, not too high. It should be optimum so that color can be seen properly. And also the B mode gain should not be very high. It should be optimum. And this whitish picture makes the color, you cannot appreciate the color flow properly. And also the 2D sector should not be too big. It should cover only the region of interest. of the 2D image and also of the color sector should not be too big. It should be, it should cover the region of interest. If you are looking at the mitral valve, keep it the sector as much as needed to cover the mitral valve. And if you want to see the aortic valve, go towards the aortic valve. That's the way we optimize the color Doppler, because only then you will get a very, very good quality image along with the color Doppler. And a little bit about the tissue Doppler velocity to end my topic. The tissue Doppler we use nowadays, each and every machine is having. So the same Doppler principle is applied, but this time it's not to the blood cells. It is rather to the tissues, as you can see with the tissue Doppler imaging. There will be a button, there will be a knob. If you switch on, it colorizes the tissues, the myocardium, the annulus, the valves. So we apply these to get the velocity of the myocardium, annulus. The normal mitral annular velocity in the septal annulus is 10 centimeter per second, and lateral annulus is 12 centimeter per second. And you have to reduce the width of the tissue Doppler imaging to get a higher frame rate, which is very much needed in tissue Doppler imaging. We utilize this tissue Doppler imaging to assess the diastolic function and to assess the LV filling pressure by getting the E by E prime values, which will be discussed in another lecture while talking about the diastolic function assessment. We also need this tissue Doppler imaging of the tricuspid annulus, where we look at the systolic velocity for assessment of the RV systolic function. So abnormal threshold is less than 9.5 centimeter per second. Now with this, I conclude my lecture. I think I have covered everything of the basic of echocardiography to start with. I hope it was helpful, and thank you for your attention. Thanks a lot. Over to you, Dr. Sinha.
Yeah, thank you very much, Devika ma'am. Thank you so much. It was a wonderful lecture. I think, is there any question from any of our colleague students or anybody? Please put forward. Any?
Yeah, any question, please? There is no question, it seems.
Yeah. So thank you all. Thank you all, and thank you, Devika. Thanks a lot.
Welcome.
Greetings from California, where I am right now.
Yes. Have a nice time. Happy holidays.
Okay. Bye-bye.
Hope it was helpful for everybody.
Yeah, it was great. It was great.
Thank you.
There cannot be anything greater than that. Thank you.
Thanks. Thank you.